All right. So we'll now move on to the Lisfranc ligament, which you're all familiar with. Here we can see it goes from the base of the second metatarsal over to the medial cuneiform in this location, Lisfranc ligament. And they're can evaluate in really all the planes. Typically, I primarily evaluate in the axial plane. If I'm concerned about it, the coronal plane can be very helpful, especially since it actually has several different bands to it. And between the medial, the second metatarsal base and the medial cuneiform, and then we also that's associated with other ligamentous structures stabilizing a lot of other structures here. Well, this is a different. Let me go back to the Lisfranc ligament here. This basically is the most important stabilizer. Excuse me, of the cuneiform metatarsal joint spaces here, and we'll talk more about that in a minute. There are much of other similar ligaments stabilizing all of the other metatarsal bases and cuneiforms, which we won't go into detail here. They're much less commonly injured, but all of them basically show thickening and increased signal intensity. And then if you have bone marrow avulsions, you get bone marrow edema and soft tissue edema in that area. And on both the dorsal and plantar aspects of each of these joints, there are ligaments which are part of the capsule, which can be evaluated. But again, they're not that commonly injured. And then in between the base of the metacarpals, also the heads of the metacarpals, you've got ligaments which stabilize those as well, which can be seen. Let me say, Michael, what do you think of this case?
Okay. So I see the Lisfranc ligament going across on the STIR image, and it looks, I mean, it's not increased in signal on STIR, but it looks a little, I mean, it looks grossly intact. But I'm wondering,
It's
I
not
don't know if
real
it's just
dark on
cut.
it's not real dark
But
on T1, and there's a little bit of increased space here.
yeah, that's what I was wondering about. I didn't know if it was the cut, but like the alignment between the kind of like first TMT and the second TMT doesn't look exactly normal.
Okay, you can see there's a little bone edema here, so there's been some
Yeah.
trauma. So it's
So I don't know if this is just a sprain
yeah,
of the Lisfranc, like a low-grade sprain.
yeah. Okay, so that's that, and then so that's just a sprain. Probably a little bit of stretching in this, but I would call this a grade 1 sprain of the Lisfranc ligament, and we can see. And then you would also have to talk about the other bony trauma here in this particular patient as well. Okay, Jennifer, what do you think of this one?
Okay, so here again we have some axial images, and it does look like there's increased signal intensity and some fluid in the region of the Lisfranc ligament. I think this is at least partial thickness tearing. There's some surrounding marrow edema.
Yeah, a lot of marrow edema. No real widening here, but there is marrow edema and abnormal signal intensity. And this again was a kind of a grade 1 strain with a lot of bone injury, traction injury to the bone. Okay, Ashu.
So just looking at this one, an axial image T1, I'd like to get to see the stirs. I can partially visualize the Lisfranc ligament there. And here you can see that there's definitely increased signal within the Lisfranc ligament. And I don't know if there is even some edema of that medial cuneiform as well, and the second metatarsal. So looks like another brain injury.
Right. We can see a lot of bone injury here, and involving the base of the metatarsals. And this one I'd be concerned about. If we look at a lot of the images, we can see that there's focal increased signal intensity within the Lisfranc ligament. And with all this bone edema, even though we don't see migration separation here, This is one that I would call either a high-grade partial tear or just a tear with a lot of bone injuries, but no abnormal separation between the bones. So this is one someone would have to be very concerned about. John, do you want to make a comment?
Well, one thing about the Lisfrank's injuries, you cannot accept any displacement. In the past, it used to be said that 1 or 2 millimeters is okay, but recently it's not okay. So the sooner you take care of them, the better. And usually you can, if it's a simple separation, you just transfix it with either screws or with K-wires. Screws are becoming more popular, I guess, from looking at the new Campbell's book. But things have gotten a little tighter in terms of treatment. And I'm sure you're going to go into the history, maybe you have already. In the past, amputations used to be the way that these were treated. And that obviously today is not acceptable, but it still can happen. I think
Okay, thanks, John.
tell everybody who they are. So I won't go into that, John.
Okay.
But you have to treat these. You don't want to miss them. Litigation is very, very common in these injuries.
Yeah, it's supposedly the #1 cause of litigation in foot and ankle injuries is missing a Lisfranc ligament.
Before MRI and CAT scans, orthopedic surgeons had to make a lot of interesting decisions.
Yeah.
Some of those decisions were not very interesting. They're interesting point.
Michael, what do you think of this case?
Okay, so it looks like there's a kind of mildly displaced fracture at that medial proximal aspect of the second metatarsal where the Lisfranc ligament attaches. So it's like essentially going to be, going to act like the Lisfranc ligaments are torn, like an avulsion fracture.
Right.
But I think the Lisfranc ligament's still intact to that bone, but it's hard to tell because the bone's so edematous.
Yeah, you can see here's the Lisfranc ligament right here, and that's those are the bone injuries which we see there. And these are in the sagittal plane again. We can see the fracture, the bone injury in there, and here the bone injury in the coronal plane. So that was a fracture right at the Lisfranc insertion. John, on a case like this, would you think it could heal okay on its own? John?
I'm looking at it right now, John.
Let me go back. There.
Do you see much of a separation there, John?
Well, what you can see that there's a millimeter or two of displacement of the bone here, the distal bone fragment. The proximal portion the bone still seems to be together.
This is metatarsal. So I'm not sure that a ligament goes into that area, but it may, and I suspect that
Here's a ligament.
It's closed by pushing on the lateral side of the foot and pushing it together, and you might be able to treat this closed without fixation.
Yeah, I think it was treated closed, but I don't have any outcome data on this patient.
No, I think I probably would treat this closed.
Yeah.
Just reduce it, squeeze it as much as possible, and put a cast on.
Okay.
And if there's any question afterwards, you have to re-examine this um, after a week and see, take more X-rays and see what you've got.
Good.
So it's something that you don't leave alone. Come back in 4 weeks type of thing, and come back in a couple of days and see what it looks like.
Okay.
And then a week, and then in 2 weeks, and then so on.
Jennifer, what do you think of this one?
So here we can see a transversely oriented fracture of the second metatarsal base. It does look like it extends through the Lisfranc, expected insertion of the Lisfranc ligament, and I wouldn't think this would be stable. I don't see that distal insertion very well.
And we can see there's a little separation here.
This one you would want to fix because I don't think it is stable, and I think you agree with that, John.
Yep, I agree. Okay, Ashu.
52-year-old diabetic male with pain and swelling for 2 months. Here we can see a pretty gross separation between the first and second metatarsal proximal bases here, and I don't really see a good Lisfranc ligament. There's a fracture of the intermediate cuneiform maybe extending through there. There's the separation and significant soft tissue edema there, and there's low T1 signal as well. I don't know if we're worried about superimposed infection here. It doesn't actually look too bad on the radiographs, which is surprising.
I'm not sure that is that the same one.
I think there's a fracture there, but it's very hard to see.
Well, here there is significant separation here. This is not acceptable. And this was what's called a divergent Lisfranc injury, and it was not called on the plain film. So this was a delay in diagnosis, which was a problem. And we can see here that there's much more separation later on. See, this is 3/24/09. It was missed on 8/18/08. And here we can see this is really getting chronic degenerative disease. And the first base is in normal position. The second, third, and fourth are laterally displaced. So this is called a divergent Lisfranc injury. We can see that there is disruption really of the other joint spaces here as well as degenerative changes occurring. And this
John, I think there has been a considerable amount of progression.
Yes.
And that's why we're seeing such a big difference between the X-ray and MRI.
Correct.
This obviously been picked up earlier, but it didn't look that bad to me. I agree. This one doesn't look that bad. I think I would probably squeeze this together and then put a cast on. I'm not sure I would. Well, my treatment of all these injuries used to be take the opposite foot, X-ray the opposite foot. I had no problem doing X-rays on both and comparing the two. And if I found other side the same as the injured side, I wouldn't get excited about it. So that's what I would have done.
Okay. So here we can see that the second and the middle cuneiform line up pretty well at the time of the X-ray. Here we can see there's been marked progression and divergent or lateral displacement of the second through fifth metatarsal bases. So this is a divergent X-ray.
But John, I think this patient has been walking on it, and because of a lack of sensation, that's what happened. And
I think that's right.
Foot.
Yep. Okay, Michael, what do you think of this case?
Okay, so this one alignment is not normal. There's multiple fractures of it looks involving the proximal second and third metatarsal bases, and there's significant widening where the Lisfranc ligament should be in between the first and second, so fracture dislocation.
Yeah, so this is another divergent Lisfranc fracture dislocation. Good.
This
Lisfranc ligament would be right here. Yeah.
this needs surgery. And what's interesting is we have straps that you can put around the foot to reduce it while you're doing surgery, so that surgery has become a bit easier. And most of the talk in Campbell's is about the classification of the Lisfrancs, and the classification can drive you nuts.
You're right.
And drive me nuts. I know that. I never remembered it and don't intend to.
Yeah. Right.
If you need it, fix it. If you don't.
So, Michael, what do you think of this one?
Okay, so there's so the Lisfranc ligament. I mean, it's gone, or it's like pretty disrupted and irregular right there. There's a, I guess there's a, is that a longitudinal fracture through the middle cuneiform, or is that part of the?
This is the cuboid. This is the lateral cuneiform.
Yeah,
I think it's partial volume of the middle.
it's just partial value. Okay, so then we have all three. So then the Lisfranc ligament was just kind of like hanging out there, with, and the there's marked dislocation of the first TMT joint, like completely separated, as well as the second TMT joint. Or the second TMT, no, sorry, the second TMT is, you just weren't catching it on that prior one. But either way, the middle cuneiform is, completely out medial to the.
This is type C2.
Okay, so this is the base of the second. That's the base of the first.
And then there's the, which is like
cuneiform. So what's happening here?
So this is a convergent Lisfranc injury.
Okay. So they're all, this is called
homolateral.
The divergent is where they separate. Homolateral is where all four displace laterally together. So it's a significant injury to the metatarsal tarsal articulations across there.
There's a C1 and there's a C2, and this one looks like a C2 plus, because there's more than just that. It's interesting because there are far more injuries to the foot that occur, like in this case, than classification. So the classification doesn't go as far as it should actually, which is interesting.
Yep. Jennifer, what do you think of this one?
So it looks like here she's 55 years old and has a history of a left foot injury. There is irregularity of that first metatarsal base. It looks like there may be a displaced ossific fragment along the medial aspect of the metatarsal base, and some of it's corticated. So I'm thinking this may be chronic or subacute to chronic fracture. And I don't see the Lisfranc ligament very well. The second metatarsal base seems like it lines up with the middle cuneiform, but I'd be concerned about a Lisfranc injury.
Yeah, so this Lisfranc is not normal. Notice here on this side, and you can see the base of the first, and here's the base of the second. This is the middle cuneiform. There's Lisfranc's ligament. Now over here, here's the medial cuneiform. Here's the base of the second, and notice there's a marked separation here. This is the normal side, so you can see the two abnormal sides. Yeah, the stir images just to show the deformity of the base of the first, and this is chronic Lisfranc fracture dislocation, and these are a lot harder to manage and tend to be left with chronic foot pain when left. Okay.
You just really cannot manage these, John. You wind up down the road amputating.
Okay,
I don't think you
thanks.
can fix these.
Right. Ashu, what do you think of this case?
Okay, so we're looking at the first and second metatarsal phalangeal joints here, and you can see a lot of edema between the first and second metatarsal joints, and there's seems to be something, a ligament that's disrupted between the first metatarsal head and the second metatarsal head right there.
Yeah. And
And there's a
also
small
notice
diameter
here,
there. Yeah.
yeah, that lateral capsule.
The
Here's the
Frank's
axial
cat.
image.
You cannot talk about Liz Franks with MP joints.
Who said Liz Frank?
Not, yeah, but now you can, but with the prior image that you showed, John, of the like this one is definitely a Liz Franks. No,
Well,
wait, hold on a second.
we're at the metatarsal phalangeal joints. I'm sorry. We've gone to a different anatomic
Yeah,
area.
we're in a different area here.
Yeah, I should have clarified that. So what we're seeing is separation here then between the first and second metatarsal heads. We're seeing on the other areas, we can see a nice capsule. There's a disruption of the lateral capsule here, the first metatarsal phalangeal joint, and then a tear of the intermetatarsal ligament here. This particular patient.
This will give you a clue that proximally there's a separation.
Could be.
I don't know if there is or not.
Yeah, I don't remember that either. And then we can see a big effusion in the joint space. Okay, Michael.
So second and third MTP pain. That on the second MTP joint, the lateral collateral ligament looks thickened, and there's some signal right at its distal attachment. So I'm wondering if it's at least, it looks fairly lax, so at least a partial tear, maybe complete tear.
Yeah. These are tears.
I
The
guess the
second
intra
and third
MT ligaments.
metatarsal. Yeah, good. Okay. So that's all I had concerning the ligaments of the foot and ankle. I'm gonna